first BRE recommendation spotlight on the opioid prescribing in older adults recommendation that has recently come out. And we today have a great group of guest speakers who will present on the information, who are part of our work group, and speak a little bit on the creation of it to the implementation of the BRE recommendation. So I just want to welcome you all and say my name is Emily Robson. I use she, her pronouns, and I'm the new Transformation and Community Partnership Manager at the Foundation of Healthcare Quality. Just as a little description of myself, I'm wearing a black and white turtleneck today. I have long brown hair and I wear glasses as well. I would like to take a moment to acknowledge that I am speaking from the unceded land of the Duwamish tribe. We acknowledge the Native people, past, future, and present, who have cultivated the land within Washington State, and their knowledge and practices that support the health of people, animals, plants, and the land in our area. So at the Foundation of Healthcare Quality, we have 6 total programs, which one of them is the BRE Collaborative. You can see we have some care outcomes assessment programs, smooth transitions, our Washington Patient Safety Coalition, and also the BRE Collaborative, which is housed under the foundation. The BRE Collaborative began because of a House bill with our legislation in 2011. The legislation recognized that there was a need to bring together key stakeholders within our health ecosystem to have a place where we could collaborate on key healthcare issues facing our Washingtonians. And so we have the pleasure of working with 22 members and different individuals within our work group who you get to hear from today. And work on some of those key healthcare issues. And each year we identify a handful that we can work on and create those recommendations. For total, we have a little over 40 recommendations. As you can see in the bottom of your screen in purple, we work closely with delivery sites, healthcare professionals, health plans, purchasers, public health, and community groups to develop those work groups with those recommendations. As 2022 comes to a close, we are excited to work on our 2023 topics next year, which will be on diabetes care, maternal mental health, and difficult to discharge clients from the hospital setting. But today we are really excited to, again, identify and recognize the hard work that this work group has been doing on opioid prescribing in older adults. And we have the opportunity to hear from Dr. Franklin, Dr. Stanos, and Siobhan Brown from their perspectives of this work. So I will now pass it over to Dr. Franklin to speak.
Thanks very much. Could we have the next slide? Thank you all for joining us. One doesn't necessarily think of the opioid epidemic as having a massive problem in the elderly or older adults. And what I mean by that is people 65 and over, because most of the people during the height of the epidemic that died from overdoses or that developed addiction were actually 35 to 55 years old. There's also, adolescents are at risk from getting opioids after dental extractions, et cetera. But there's a very specific problem in older adults. In 2018, the Agency for Healthcare Research and Quality highlighted the increasing rates of opioid-related hospitalizations in older adults, with the highest reported median rates being in Oregon and Washington. So a little bit shocking. And then while opioid prescribing and mortality specific to prescribed opioids has fallen to a large extent, the CDC did report that the specific opioid-related mortality rate for people 65 and over increased by 4.8% as the only age group in which the rates were not falling. In fact, they were going up. The next slide. The next slide, please. So these opioid-related harms have been increasing among older adults. And part of that is related to the fact that even when used as directed, older adults are more likely to experience adverse drug reactions, falls and fractures, and then ED visits, hospitalizations, and death. And then opioids, of course, may exacerbate other pre-existing conditions such as cognitive impairment. Next slide.
I'm sorry, there's a little lag between me clicking it, so bear with me.
Now, there are unique challenges for assessment and management in this age group. Number one, the age-related changes in pain perception and thresholds or differential aging effects on this. The responses to medication are highly variable with higher peak drug levels, delayed clearance, longer duration of action, and higher rates of side effects. There's also, of course, multiple comorbidities, including both medical and psychological, that results in polypharmacy, which also interacts with the opioids. And then, of course, psychosocial concerns and lack of care coordination is a generalized problem in this age group. The take-home message here is that we really need an integrated, a more integrated and coordinated and individualized approach, particularly important in the over 65 population and the Medicare population to assure optimal pain management. The next slide. The work group had 6 areas that we focused on in regard to recommendations, and I'm going to go through some of the recommendations, but not all. The full report is very robust with a lot of stuff, but I'm just going to hit the highlights here in this presentation. The next slide. Just a high-level summary of it all is that there is very little high-grade evidence on exactly what to do in this age group in regard to opioid prescribing. However, it is still true that about 6% of opioid naive adults over 65 still transition to chronic opioid use after acute opioid use, say from acute pain or after surgery. The approaches to opioid prescribing and pain management should be focused on function and safety, the overall recognition of needing to start low, go slow, and stop soon. And then there will be key recommendations that I will go through as well. But one of the main ones is to make liberal use of non-pharmacologic pain management modalities, to develop individual care plans, to perform comprehensive medication review, to coordinate care, and specifically to use pharmacists and multidisciplinary teams, which have been proven very, very helpful in dealing with these kinds of issues. The next slide. The first set of recommendations have to do with healthcare sites or delivery systems. And number one is to expand access to the kinds of services that I just spoke about, such as integration of care and use of pharmacists. Provide adequate access to at least some non-pharmacologic modalities, including connecting to older adults, not only to what their benefits are in their healthcare plan, but also to community resources, which some things, for example, like yoga, might be available very cheaply through the community, but maybe not always through the health plan. Expand coverage for topical medications. Track and monitor prescribing. Track prescribing practices and drug-related adverse outcomes. Set the expectation for standardized medication review, including reviewing the prescription monitoring program, conducting comprehensive medication review on at least an annual basis, provide clinical decision support tools within the electronic health record, including integrating the PMP into the EHR, and establishing the infrastructure to provide medication therapy management, including those annual comprehensive medication reviews that I mentioned. The next slide. The next slide.
I think
So
this is what we have for Dr. Stanos to
yeah,
review.
I somehow you got off of my slides here.
Okay, give me one moment.
I think I was ready to go into the acute care recommendations and switched over to Stephen.
Yeah, I was all ready to go, Gary. I know. Hold on. Getting me all warmed up, Gary.
Which is different than hot and bothered.
That's good. Well, and I can say as Emily's doing this, I'm Stephen Stanos. I'm a physiatrist and pain specialist at Swedish. Just working with the committee, we really had a multidisciplinary group of psychologists, pharmacists, geriatricians, primary care doctors, pain advocates. So it was really a fun experience. And I think even though it's really hard to always look at the literature and make guidance, we really, I think, balanced it out pretty well. So hopefully Gary's going to be able to get through. I think he was going to review kind of an overview of the 6 focus areas, and I'll try to do the same and more around how it's how a clinician can utilize the guidelines.
How are we doing there, guys?
Great. I'm going to share it right now. This is what I have as your next one, I believe. I'm not sure what happened. Apologize for that. Thank you, everyone. This is what I have.
Additional healthcare site and delivery system recommendations include team-based care, including developing multidisciplinary collaborative teams to support older adults with acute or chronic pain, and to improve access to specialty care for patients, especially when they're beginning opioid tapers. This can be an extremely difficult task, even in the best of circumstances, but getting some specialists involved for that would be great. And then educating older adults and their caregivers about non-opioid pharmacologic pain management options. This should include education on the potential dangers of polypharmacy and the benefits, in some cases, of deprescribing very carefully. The next slide. So the top line recommendations for the focus area of acute prescribing: number 1, there should be a designated provider to be responsible for managing ongoing acute or postoperative pain, including prescribing any further opioids and the policies on refills and patient reassessment. Secondly, start at 25 to 50% of what would be initiated in a younger adult and extend the dosing intervals. Next, avoid using long-acting I'm sorry, not the next slide. Avoid using long-acting opioids for acute pain. These should not be used at all in most cases of acute pain. And then perform medication review and reconciliation at follow-up visits to ensure the patient is not continuing medication that they no longer need. And I want to call your attention to these 2 documents, one on the Interagency Guideline on Prescribing Opioids from the Agency Medical Directors Group, and then from the BRE Collaborative, a document on prescribing opioids specifically for postoperative pain. It's an excellent document with a lot of specifics in there about various kinds of surgery. The next slide. We have one small set of recommendations on intermittent opioid therapy. This is in older adults who have chronic pain, who are not on opioids, but they might have flares of their chronic pain. So one might consider prescribing low doses of intermittent opioid therapy for these patients that have these sporadic pain flares, but only if it is demonstrated to improve physical and social engagement. If you do that, use the lowest dose of short-acting opioids possible, avoiding any kind of prolonged more than a few days of opioids, and avoiding continuous around-the-clock use. Reevaluate frequently for risks of falls, sedation, etc. The next slide. The next area is on co-prescribing with opioids. This is a whole nother large section in the report, but this is just the essence of it. Consider non-pharmacologic modalities in all of these areas for pain management to prevent co-prescribing opioids with CNS active medications. For qualifying Medicare patients, encourage the participation in medication therapy management program, thereby ensuring access to an annual comprehensive medication review and quarterly targeted medication reviews as indicated. Taper other medications if possible prior to prescribing opioids to limit exposure. Avoid combining opioids with gabapentinoids. The exception is if you're using gabapentinoids to help reduce other drugs. And then deprescribe CNS active drug combinations whenever possible. The next slide. So on non-opioid pharmacologic pain management, use first-line consideration, give first-line consideration to acetaminophen and non-steroidal, non-systemic topical medications, such as topical non-steroidals. Give particular attention to renal function and consult professional resources such as the Beers criteria for potentially inappropriate medication to use in older adults. So these are examples of the Beers criteria that are really specific. So initial non-opioid medications are Tylenol and topical analgesics, medications that you should still use possibly with more caution, NSAIDs, SNRIs, and gabapentinoids, but should be avoided in combination with opioids. And then medications to avoid are tricyclic antidepressants and muscle relaxants. The next slide. And then non-pharmacologic chronic pain management, strong recommendation to make available at least several modalities as safer alternatives to pharmacologic therapy. Some modalities can be accessed by insurance or alternative resources, such as community organizations. Cognitive behavioral therapy and exercise have the strongest support for multiple chronic pain conditions. The work group, however, are recommending several others of another 8 or 9 types of non-pharmacologic chronic pain management. And then consideration should be given for multimodal approaches that may have benefits beyond improving pain and function, such as Tai Chi may help both pain and balance, thus reducing the risk of falls. The next slide. Tapering and deprescribing. I'm not going to go into too much detail here because the BRE Collaborative has an entire report on this, but the main thing here is that there's a risk of too rapid a taper, and you have to be very careful to go very slowly in every single patient. The other thing is to offer non-pharmacologic therapies while you're trying to taper. The 2020 BRE Collaborative Guideline on long-term opioid therapy includes all of the details and algorithms that you need to possibly know. Ensure that tapers are negotiated with the patients, and the speed of the taper does not exceed the guideline recommended taper speeds. Ensure that all providers offer a patient a variety of non-pharmacologic treatments, and ensure that every patient is assessed for opioid use disorder. And if necessary, if you have trouble tapering, it very likely means that the patient has severe enough dependence or opioid use disorder that medication-assisted treatment is likely indicated. And then assess each patient for anxiety, depression, suicidality, and insomnia, and treat those appropriately. The next slide. The next slide. Next slide.
That was the last slide we had on your deck, Dr. Franklin.
Okay, so that's it for the high-level recommendations for the 6 areas that we covered in the work group. And if anyone has any questions, we can certainly chat offline after this webinar. Stephen?
So Dr. Stanos has been having some internet troubles today based off of where he is located. It looks like he might have been off. So if that is the case, we'll move forward. Oh, wait, he's here. One moment. As we get him back as a panelist. And then we can have
Oh yeah, this is Stephen. I'm sorry.
That's okay. It's we are now to you.
Okay, and I'm just going to use my phone. I apologize. I can still see everything on. Gee. Okay, so thank you, and I apologize for the technical difficulty. I'll keep my camera off just to try to save my Wi-Fi here. But like I said, as one of the members of the task force, we really enjoyed working on this. I think the key take-home message, like Gary alluded to, was that these are older patients. There's other medical comorbidities, so we want to use the same best practices that we use for any patient, but really be cognizant of those other issues. And like Gary said, even with acute prescribing, a small percentage of those patients may transition to chronic prescribing of opioids, and so really being careful about that. And so obviously we won't go into a lot of details, but be familiar with and have a good system for checking the PMP, doing urine monitoring, all those other things that would be part of our best practice and within the rules of the state. And I think the key is that this is still a biopsychosocial problem for patients, and so we want to assess it that way. So what I'm going to do is go over the 6 focus areas. I included the first 3 here, for the first being acute prescribing, and the goal is some of this may be repeated from what Gary talked about, but almost give some insight on how you can use the guideline and integrate it into your practice. I work in Seattle and in the Issaquah clinic, so I'm seeing many patients, many older patients, and so I've learned over time we can kind of integrate a lot of these even non-pharmacologic techniques while we're doing a lot of medication management as well. So the first focus area was on acute prescribing, that being acute prescribing for pain as well as in the perioperative period. Prior to starting a patient, you want to perform a risk assessment. We use the opioid risk tool, which I think is really just a good social history, because that gives me a better idea of some of those risk factors like depression, anxiety, previous substance use that may put them at risk, even for an acute patient, to develop problems with opioid use. I think the key with patients is to really get them engaged and to make them proactive in their pain management. And even with any type of prescribing for acute opioids, establishing short-term goals with the patient. And I keep it simple in my clinic, 1 or 2 goals, things that they're not able to do that they want to do better. And then I document that and follow up on that. Like Gary said, it's going to be important for those post-operative patients or patients that are going to be going to surgery. And this is very important, especially with our elderly population. They may have joint replacement surgery, other elective surgeries. You really want to reach out to the orthopedic surgeon or the team that's working with them and decide on who's going to be managing that patient. We already have very good AMDG guides and BRE guidelines, on opioid prescribing for the perioperative period. And it nicely breaks down the duration of management for those patients. Based 5-minute phone call to the nurse or the team member that's working with the orthopedic surgeon is really good, especially when this is a little different when you have a patient that's already on opioids and you're trying to help kind of develop a good plan so the patient's not left kind of hanging when the surgery is done and this isn't organized. When initiating patients, because they are older, the group decided on 25% to 50% reduction in dose. Another study had said you could reduce in 25% dose in patients at 60 years of age and consider 50% reduction if they're 80 years of age. And I think that just underscores the pharmacokinetic and pharmacodynamic changes that patients undergo that are older. And so it's always better to start lower and then you can titrate up on the medication. With that, you really want to see these patients quickly. You don't want to give them a month's supply of medicine or a plan where you're not going to see them. We like to get patients for acute prescribing back in the clinic within 1 to 2 weeks, or even do a virtual visit, so we can really make sure, was the medication effective? If not, stopping the medication as well as adjusting things. Other things to look for are the risk of chronic use. Like we said, I use the opioid risk tool to help with that. You want to use the shortest duration and really avoid complicated regimens. Only use short-acting opioids with these patients that are acute prescribing. And I think what's most important is during the discharge and follow-up, seeing the patients, monitoring them for what side effects they're having,
a significant problem with falls and cognitive impairment can be worsened with these medications. So you really want to have an open discussion with your patients, as well as engaging the family members. The second part was on intermittent use, like Gary alluded to. The only thing I would add, if you're going to use opioids for sporadic flare-ups, really do a good physical exam. This may not just be an aggravation of their pre-existing pain. It may be a new pain condition. You could have a patient with shoulder pain. The pain is worsening. It could be cervical radiculopathy. It could be something different, or it could be disease progression within that. So obviously, not just increasing their meds for a short period of time, but following up with a good physical exam to reassess what's really happening. And I also, with intermittent use, you setting the expectation. We usually give 2 to 3 day supply for patients of opioids for those types of intermittent use, and then get them back in the clinic. The next is co-prescribing with CNS active medications. There's probably no bigger group that this is going to be impacting than our older patients. Again, because of the pharmacodynamic and all the other pharmacodynamic issues that they have. We broke this down into two parts, prior to initiating, and then what do you do with patients that are already on opioids, but they're also co-prescribed with CNS active agents. For the prior to initiating a start of an opioid and they're already on, say, a benzodiazepine, you really want to consider other non-pharmacologic measures. Just because a patient's older doesn't mean they don't have untreated depression or anxiety or coping skills problems that behavioral health brief intervention could help them with. So don't always think of this as going to be a medication that's going to solve the problem, but really maximizing those other treatments. If you're going to start opioids, really doing a good medication review because you really want to be aware of any potential drug-drug interactions. And again, that's going to be so much of a problem with our older patients versus the 30-year-old that you may see who doesn't have those other medical comorbidities. You really want to avoid starting benzodiazepines, but the other central nervous system acting agents we want to be careful about are the GABAergic medications, gabapentinoids, like gabapentin and pregabalin. And what are the other non-pharmacologic and pharmacologic things you can do? If they're already on benzodiazepines, for example, coordinating that with the psychiatrist. Is that appropriate for them to be on? Understanding the risk of starting opioids with benzodiazepines is going to be important. And I think with the electronic medical records now, you can message many of your colleagues if they're in your system while you're in the visit with the patient with those kind of questions. So I think it is easier now to coordinate care. Separate from picking up the phone and calling that provider and having a good plan for the patient. You don't want to stop their benzodiazepine and destabilize them. You really want to have a good coordinated effort with the psychiatrist or the other people that are working with that patient. Gary mentioned if they do have Medicare, could they qualify for a medication therapy management program? That's where a pharmacy can really go through and do an excellent job to review the medications. At our system, we don't have that capability. But I have been using the annual wellness visits that our patients get with primary care. Those are usually very well documented in the chart. And I use that as my annual event to go through the medications and the other medical conditions patients have. And I can review that and get a good sense of how things are going outside of their pain condition. And many times it's a good time to review the medications as well. So you can kind of indirectly use the wellness exams that our patients are all doing now through primary care and use that as a way to guide you through reviewing medications and making sure they're safe. Next slide. For non-opioid pharmacologic management, avoid unnecessary polypharmacy. Oh, you can go back, sorry. There we go. But remember, with the non-opioid pharmacology, a lot of this could include the neuropathic pain medicines. Many of our patients have diabetic peripheral neuropathy. They may have post-herpetic neuralgia. And so those non-opioid medications can be helpful, but you want to be careful as well. They can also cause cognitive impairment, increase in falls, balance issues, and other important side effects that could lead to significant harm. And also, if you're going to use multiple medicines, especially with neuropathic pain management, where we're trying to focus on different mechanisms of action, whether it's calcium channels, magnesium, sodium channels, those patients are going to be on multiple medications, and you really increase the risk of drug-drug interactions. So our group recommended as first line acetaminophen. Average doses are 2 to 3 grams. Maybe for short term, you can go up to 4 grams per day. I think any patient on acetaminophen, you want to be also questioning the amount of alcohol they're drinking, because that can really tip the scales and cause significant liver toxicity. So especially with our older patients, they may have been drinking small amounts of liquor for many years. Taking a good history of alcohol use is going to be important. The other first line options are topicals. There's been a huge increase in the use of topicals, and the formulations are better, whether they're over the counter or prescription strength. But be familiar with those topicals. Know the difference between the different diclofenac products that are prescription strength. If you go in a pharmacy, there's a whole over-the-counter aisle now of different thermoreceptor topical analgesics. And so be familiar with a couple of those so you can help guide your patient as well. And then use caution with oral NSAIDs, again, because of the cardiac, GI, and renal effects. In our older patients, if we are going to use anti-inflammatories, you want to know the anti-inflammatory dose and the analgesic dose. It's better to have a dose that's actually going to work, but have them use that medicine for 3 or 4 days in a row and then stop it, instead of having patients on chronic NSAIDs and leading to other problems. So we call that kind of pulsed use of more therapeutic doses of NSAIDs if we're going to use it in elderly, but have a good discussion with them about the risk and potential harms of those meds. Can be very valuable for our patients, especially for neuropathic pain. But understand and do a good review of the doses that they're taking. Are there cognitive impairment? Is there dizziness? Anything else that can impair those patients? And I think a lot of times the gabapentinoids and the antidepressants, we forget some of the side effects that they have and think these are just opioid types of side effects. So there's use caution with gabapentinoids, the SNRIs, and we strongly recommend against the use of the tricyclics. There's just too much anticholinergic side effects. We have better agents now, like the SNRIs, that potentially have maybe less side effects than the tricyclics. But unfortunately, in our older populations, can also cause hypotension and other, systemic effects that can be dangerous. So next slide. Number 5 is the non-pharmacologic pain management. In our clinic, we use a lot. There you go. We have our own psychologist and relaxation therapists and physical therapists. There is strong evidence for cognitive behavioral therapy. We have a lot of older patients that have never spoken to a behavioral health person. Any patient that's older can talk to a behavioral health person during their lifetime about anxiety, stress. Our elderly patients have just the same amount of stress that we do as younger people. And I think sometimes that's ignored. So, having access to CBT, to behavioral health, a lot of those interventions now are done virtually. So a lot of our elderly patients can do this from home. So I think it's really opened up the access to that. So be familiar yourself with different apps. There's a lot of great apps that include mindfulness, other deep breathing. So I think you as a primary care provider can really start to use those apps and tools to help train your patient who maybe can't get into a behavioralist for counseling. So be familiar with some of those apps, but really you want to focus on improving engagement by the patient. You can consider there's evidence for chiropractic treatment, for mindfulness, Tai Chi. Our physical therapists are trained as well in Tai Chi. So even through their physical therapy benefits, you can find different PTs that can teach Tai Chi. Like Gary alluded to, there's a lot of community-based programs that are free that include yoga and Tai Chi and exercise. So really start to use those, and that's going to be an important part of your treatment, just like the medication that a patient's going to be. So again, we feel there's a lot of evidence for the non-pharmacologic treatments in our elderly population. You just want to really set expectations. When I send patients for physical therapy that are older, I ask them to have 2 or 3 exercises they can review with me when they return to clinic at their follow-ups. And we focus on 2 or 3 exercises, or getting them into a walking program. A lot of evidence for just aerobic exercise, and that can help our elderly patients. So you just want to be a little more creative, and I think it makes the patients more engaged. And then the last part, number 6, was tapering and deep prescribing. We know this can be dangerous in some patients, but you really want to first reassess what's going on. Is there underlying depression and anxiety? Is it appropriate for them to be on the opioids that they're taking? If it isn't, what is the slow taper going to be? We usually decrease by a small number of pills per month, and that way we avoid any kind of withdrawal and I think the patients kind of can break through the behavioral aspect of being used to taking medications. But you really want to first stabilize your patients, and you really want the patients to trust you. And many times this is going to be a de-prescribing effort. It's going to take many visits. You may hold the taper. You may sometimes have to increase their dose for a short time. So those are the recommendations. I really thank the brief for letting me quickly go through this. I'm sorry about the technical difficulties, but again, the guidelines are really biopsychosocially based, and really remember the frailty of many of our elderly patients, and you just want to be really careful and monitor patients a lot more than even what you're doing.
Dr. Stanos, I think we may have lost you. Oh, there you are.
I'm sorry. Are you here? I'm sorry.
That's
Next
okay.
slide. I'm sorry. I kept thinking I was off. Can I do the last two slides, or am I out? I apologize.
If you want to quickly, if you could do it in a minute.
I'll just summarize it. Yeah. So the next slide. Yeah, and so I did include the CDC guideline, the updated 2022 recommendations. The 12 recommendations were released in November. This is, because of time, I won't go through that, but very evidence-based. They removed the dosing thresholds. Not that we're saying that higher doses don't cause problems, but I think they do a good job of breaking down the difference between an opioid naive patient versus a patient already on opioids. And so a lot of those, the 12 recommendations, I think are all in line with a lot of the things that we said in this guideline. But I just wanted you all to be aware. You can quickly Google this, and hopefully we'll be doing more outreach about the CDC updated guidelines from 2022. So with that, I'll turn it over, and I apologize for the technical difficulties.
Great. We'll now have Siobhan Brown speak. Thank you, Dr. Stanos.
Hi, I'm Siobhan Brown. I am a senior program manager at Community Health Plan of Washington. Community Health Plan of Washington is a nonprofit community health plan that's based here in Washington State, and our lines of business are focused on Medicaid managed care, Medicare Advantage, and Washington's public option plan, Cascade Select. So my work at CHPW focuses on intersection between program design and systems and policy work. And one of the topics that I focus quite a bit on is around opioids, from opioid prescribing to harm reduction options and access to opioid treatment as well. And because this work is focused on older adults age 65 and over, the majority of these individuals are enrolled in Medicare. And to give a sense of the scope of this within Washington State, in August 2022, there were nearly 1.3 million individuals ages 65 and over enrolled in Medicare in Washington State. And one of the reasons that I was really interested in participating in the BRIE Collaborative Work Group on this topic was a number of years ago, I was reviewing AHRQ data around opioid-related hospital stays, and I did learn the same statistics that Dr. Franklin presented earlier about Washington having some of the highest rates of inpatient stays for older adults related to opioids. And just as an example, as a payer in Washington for Medicare, we do track information like this, and this is for all of Washington, not specifically Community Health Plan of Washington, but in the first quarter of 2008, there were 700 opioid-related hospital stays for older adults in Washington, and by the second quarter of 2017, there were 3,000. And so that's a significant increase over time in these opioid-related hospital stays, and really drew me to this work, as well as seeing how my own aging parents were engaged with their healthcare and how they could navigate through their insurance to ensure that they were receiving the best care. So in 2020, there were about 1.3 million opioid claims in Washington through Medicare Part D plans. And so that's new prescriptions and refills. And that's a lot of opioid claims. But we do see some good news in this, that the trend is a fairly consistent one in a reduction, because in 2014, there were 1.6 million opioid claims through Part D. So there is good news in that these prescriptions are decreasing over time within Washington State for older adults. So I'm just going to briefly review the recommendations from a health plan perspective. And I do want to set forth at the beginning that this is from a perspective of Medicare Advantage. As a Medicare Advantage plan, I can speak to that. There are some individuals enroll directly through original Medicare, and I won't be touching directly on that today. So Dr. Franklin reviewed the general recommendations for health systems and health plans earlier, and one of those is expanding access. So health plans in this space can review their non-opioid and non-pharmacologic benefits for pain management. Within that, potentially considering how to improve access to things like topical medications, or improving access to their over-the-counter benefits, or offering over-the-counter benefits if they don't already. One of the, while Medicare Advantage plans offer some standard physical and mental health benefits, we also offer a lot of opportunities to help address pain through non-pharmacologic means, such as fitness programs. You might be aware of Silver Sneakers or Silver and Fit. These are opportunities for older adults to engage in fitness activities, including yoga, Tai Chi, guided fitness classes, that they can do both at home if they have an internet connection and a computer, or going to the fitness center. So there's a lot of opportunities there within Medicare Advantage for people to help address their pain needs through these activities, also offering access to acupuncture and chiropractic care as well. So there's a lot of opportunities there for Medicare Advantage plans to review their benefits and see what they're offering to their health plan membership, to make sure that they have a broad range of non-pharmacologic opportunities there for addressing pain and fitness. Another thing that health plans can do around expanding access is looking at their transportation benefits to help support older adults in accessing services that are offered outside the home, such as chiropractic care, acupuncture, and those fitness classes that are offered only within a fitness center. Within the recommendation for tracking and monitoring prescribing, Medicare Advantage plans do monitor the utilization of opioids and overutilization of opioids, and do attempt to engage providers and their health plan members when prescriptions are being received from multiple providers, or when high doses are being prescribed. So that's another avenue for Medicare Advantage health plans to take when considering what how they're engaging in this space. As has been mentioned a couple of times already, the comprehensive medication review, that's something that's required by the Centers for Medicare and Medicaid Services for all health plans that offer Part D coverage, which is the drug coverage. And so medication therapy management is offered to health plan members who meet specific eligibility criteria. And those eligibility criteria are set by CMS. And individuals are not required to participate in such a review, but if they do, it offers them the opportunity to spend quite an in-depth amount of time, up to maybe a half an hour, in a visit with a pharmacist from the health plan, reviewing their medications, talking about drug safety, asking questions. And then they receive a summary of this discussion, and they're encouraged to bring that with them to their annual wellness visit. So that's an opportunity that health plans offer, but this is also something that health systems can invest in, and there are billing opportunities within that for doing some of these medication management reviews within the health system. Medicare Advantage plans, within the recommendation for team-based care, we recommend using integrated care teams to comprehensively review health plan members and their complex needs. These teams within the health plans often consist of physicians, pharmacists, case managers, other health plan staff that might be relevant to an individual's specific needs, such as nutritional support or community health workers. And providers should be offered the opportunity to attend and participate in these reviews. Understanding that providers are quite busy, the health plan case managers can follow up with the provider afterwards and provide a summary of the review that's been conducted by the health plan. And then from the recommendation on education, which is the final one, I really see from my perspective within the health plan, but also within my own life with my own parents, really better education of our health plan members about their benefits. Participating in this free collaborative review, I really heard a lot from providers and patient advocates about confusion about what benefits people have and understanding how they can better support their patients. So as health plans, we can really do a better job of ensuring that our members know about their benefits, what options they have, making information more easily accessible on the health plan's website. And then supporting health plans, supporting healthcare providers and the health plan members with access to shared decision-making tools. These tools can be really helpful and are very important around opioid decision-making, but they cost money. So helping make those accessible to providers and health plan members to go through those tools. And then also educating our health plan members on their options around pain management, around medication interactions, and those types of things. So those are just a summary of the ways health plans can help engage in these recommendations and support their health plan members and their providers.
Thank you so much, Siobhan. So I would like to invite you to stay on, and I'd like to invite Dr. Franklin and Dr. Stanos to join us again as we enter our Q&A portion of the event. As a reminder, those of you who are present right now, please enter any questions into the Q&A bar at the bottom of the Zoom screen. It looks like we already have 3 questions that we can start by going over, but we'll try to get through as many questions as we can before the top of the hour. Another reminder, I noticed that we had a few questions about a recording link and slides, and we will be sending those out to all those who registered for this event within a week of today. But moving on to our questions, our first question is related to older adults who need long-term opioids to manage chronic pain, who currently live in skilled nursing facilities, SNFs, or other long-term care facilities. And this person was wondering if you have any recommendations about opioid formulations or frequency to recommend to these settings in particular.
I think I'll let Stephen get that one.
Oh, thanks. Yeah, I think the question, so I get this right, is in like extended care facilities where patients may need to be on opioids, what are the kind of more preferred formulations? I think with any of these patients that are new starts, really staying on short-acting opioids, hydrocodone, oxycodone. I think what we're not just the patients that are in facilities, but even in the clinic, really getting a good idea is the opioid helping them? So when they take the medicine, how soon does it help them? How long does it last for? Really, what I see in charts is there's really not a lot of monitoring of what their actual response is. And so I think that's going to be really important because, if they're in a skilled facility, maybe they're not as ambulatory, they may be at more risk for falls when they do get up. You have to be really careful with those patients. So I think it's, keeping maybe scheduled doses at the beginning so you can get a better idea. What I hear from my patients that are in some of those facilities, sometimes it takes a long time to request the medicine and that becomes problematic. So it may be scheduled, but then if it's going to be scheduled, making sure that it's actually helping them. And so are there certain times of the day, like 8 a.m. and 12, that if they took an alert, you want to be really clear what the plan is. So keep it simple, really try to keep them on one type of opioid, not multiple opioids. But at the same time, those same patients, I see a lot of overuse of multiple muscle relaxers that kind of get piled on. They may be on 2 different types of antidepressants. So I think taking a step back and first really doing a good medication review and making sure, do they really need to be on what they're taking? And cleaning that up first, and then maybe starting an opioid trial if you're going to do that. I hope that answers the question.
Yeah, thank you so much, Dr. Stanos. The next question that we have asks, could you comment on the perception that the pendulum has swung such that we are under-treating pain for fear of potential opioid use disorder? Seemingly, our recommendations are prioritizing doing no harm over alleviating pain and suffering, but we might be missing patients who need opioids for chronic pain. So I don't know, Dr. Franklin.
Yeah. I'll go first and then Stephen can chime in, I'm sure. The first thing to understand is that opioids have not been demonstrated to be long-term beneficial in improving pain and function in patients with many chronic pain conditions, such as chronic low back pain, chronic musculoskeletal pain, fibromyalgia, and headaches, etc. That I'm not commenting here on end-of-life care. I'm not commenting on, say, severe, pain, chronic pain with lots of like sickle cell disease, etc. The evidence on long-term opioid use is very, very weak for most chronic pain conditions. Also, Jamie, Mai, and I reported the first deaths in the country from prescribed opioids, and it was rather shocking to see 32 injured workers die from the drugs, from the prescribed opioids that were given to them by their doctors. These were not necessarily extremely high doses, but if you shoot the dose up or use fentanyl or some other very powerful drugs, you can go to sleep and not wake up. So I'm not including that in the pendulum. I think the only thing that I think the one pendulum thing, if you want to say that was a pendulum, is perhaps some health plans or public payers or Medicaid overreached from the 2016 CDC guidelines on dose, that doses were interpreted probably too strictly by some payers, and that may have led to some problems such as other issues, including possibly suicide. However, I don't think there's any question that you should be extremely careful about preventing transition to chronic opioid use from acute opioid use for most acute and post-operative pain conditions. That those are totally unnecessary transitions. So I don't agree in the same words with the pendulum. There may have been some piece of a pendulum, but and we have to be very careful about that. When Stephen mentioned on the new guidelines, it's very important to differentiate in those recommendations the opioid naive patients from the patients on chronic opioids. So have been already on opioids for at least 3 months, or sometimes months or years. So I personally, the evidence is still very, very strong, and that never changed. In fact, the evidence in the 2022 guideline is even stronger than it was in 2016 for dosing thresholds and for days use with acute pain. But the key problem became patients on chronic opioids, and we have to be very careful with those patients. Stephen?
Yeah, and I'll just mention it, and I think there's probably some things, I think there is some evidence in some patients that opioids can be beneficial, just like a lot of different pharmacologic therapies that we use. I think the pendulum question is always tough because, like Gary said, it's very complex. There was overuse, there was overprescribing, there was diversion. I think the big issue now is that prescribing is going down, which is excellent. We're not seeing these patients on really high doses, but how do you balance out the patients that still benefit from this therapy and just doing evidence-based kind of best practice, patient-centered care, really. So I think the new CDC guideline really reflects back on that you really want to look individually at each patient, because this is really hard to look from a research standpoint, how their outcomes are going to be. Again, I think what I see as a clinician is many times people just concentrate on the opioid, but they're not maximizing these other medications, and they're putting all their eggs in one basket. So I've been able to get patients' opioids down. They still may use them occasionally, or we lowered the dose, but then they're using other interventions to treat their pain. So I think what happened with the pendulum issue was in the past that it was just thought of that you could just give opioids and that we weren't really doing a good job with the other types of treatment. And so separate from a person that develops opioid use disorder and needs the right kind of treatment, I think we're doing a better job of identifying that. So I really think we need to be looking individually at these patients and just being a lot more cautious, because I think that's what the pendulum taught us. That being said, there was also, like Gary said, the misapplication of the guidelines, and patients were being denied medicines, destabilized. There was overdoses. Now we have illicit fentanyl. So the supply out there, the illicit supply, is so much more dangerous than it used to be, which is another thing to consider for your patients. So it's a great question. We probably could have a whole webinar just on the pendulum. But hopefully the new guidelines in this guideline for geriatrics, older patients, I think is very reasonable, very practical. If we can just get back to the good evidence-based care and being cautious with patients, whether they're on opioids or gabapentin or any medicine, we really need to monitor these patients closely.
Yeah, thanks, Dr. Stanos and Dr. Franklin. I think we have time for one more question, as we have about 4 minutes left. So I'm going to take both of the next questions in the Q&A. The first question says, can you address the importance of shared decision-making when treating pain patients? And I'd like to start with Siobhan, because we have a second question that asks, Specifically, Siobhan, can you share an example of a shared decision-making tool that is useful but expensive?
Thanks. I think there are a lot of shared decision-making tools out there around different topics, and all I meant to highlight is that shared decision-making tools can cost money. They don't all cost money. Some are available freely, and many of those are developed by research institutions, but there are also shared decision-making tools that that providers would have to pay for. And so what I wanted to highlight in that was that making sure there's a variety of shared decision-making tools available to your health plan members as well as your providers, and those that cost money could be made available by the health plan for free. So I think it's something we have to pay for, but it provides a lot of benefit. So there are a variety of tools out there and that are available for opioid decision-making that are free as well.
I'd like to say that I think that this is Gary Franklin, that classical shared decision-making in its best use was expensive. It involved some very sophisticated tools, and it was most effective for conditions like prostate cancer, for which the evidence, there's legitimate issues around whether to do this or whether to do that. I actually don't really agree that shared decision-making can be all that effective with controlled substances. I do think that prescribers need to be extremely explicit about the risks and the possible benefits with any of these kinds of drugs. But I don't think that the classic shared decision-making that's been very useful for when there's really the decision is not that clear and the patient needs to be pulled into the doctor's thinking and decision-making and the evidence. But I personally don't think that works all that well for controlled substances.
Yeah, I would just add, I mean, I think just more from a practical standpoint in clinic, I'm thinking about many of my elderly patients have caregivers or family members that bring them in. They've got really severe arthritis, let's say. They can't have surgery. We're trying to balance out, can we get them up walking a little bit? They have some quality of life. Having that discussion with the patient and the family member, and you really need to get the patient engaged. So I look at shared decision making as the patient tells us what they think they want to do. We explain the risks and benefits, the potential harms, and what's that ratio of risk versus harm with the patient, and does the family agree with it, and does the patient agree with it? So I think you do need to document that and have that discussion. But I do think with a lot of our elderly patients, a lot of times are in clinic with their family members, and it gives you a better insight of what's going on at home. So I would say take advantage of having those family members helping in the shared decision making, and really do like very simple goals with patients, because the patients obviously have to set the goals, and that's going to be key. And then they're more engaged in what's going on.
Perfect. Well, thank you all so much for being here. I see we are at the top of the hour, so we will have to close here. But again, thank you to all of our speakers for both participating in our BRIE work group on opioid prescribing in older adults and for sharing what we learned today. For all of you who are still on the call, thank you for attending our inaugural recommendation spotlight webinar. We do have more webinars upcoming for our other 2022 topics, with our next one next Wednesday at this same time on outpatient infection control. Emily, thank you for putting those links to sign up in the chat. Additionally, the BRIE has chosen our 2023 topics, and if you are interested in being part of a work group that talks through some of these issues that Gary, Stephen, and Siobhan were talking about today, please feel free to reach out to me and I can get you connected for our 2023 topics, which are diabetes care, difficulty to discharge, and maternal mental health. But thank you again, everyone, for being here today, and I hope we see you again at another BRIE event. Thanks.
Thanks, everybody.